we're going to have two talks from Lachlan today. So most of you have met Lachlan in some guise. He came to us as an honours student, then stayed on and is doing his MPhil, which I believe you're submitting on the 22nd of January. No Christmas holidays for Lachlan. And then he's off to medical school, and then he'll come back, and then I can retire and he can have my job, which is all in the master plan. And again, acknowledging the support of Maddie's soldiers who have funded this research, and following on from what Joe and Chris have talked about in terms of losing blood from your nose and how important it is for you not to become anemic. Lachlan's going to talk about our teeny-weeny study of intranasal avastatin.
All right, well, everyone, so I'm Lachlan. I'm the research student who's been working there. So hi to all the unfamiliar faces and to the familiar faces as well. And thanks everyone for coming in today, or for anyone listening on the recording for taking interest. So I want to talk today about the research that I've actually been doing the past couple of years. And this is something that we went into mainly last year, but it did extend through to the beginning of this year. So before I can really talk about what we did and what actually happened, I'd like to just sort of give a bit of background in terms of how we thought through this actual project. So these are the genes that we know of that cause HHT. This is a breakdown there, and they all fall in this pathway that is colorfully illustrated, but still rather confusing. But effectively, while each of the genes has minor variations, they have ultimately an effect within this pathway that causes a problem at the end. And this is the sort of unit of disease that we're dealing with, the arteriovenous malformation. So I've made a lot of use out of this diagram, for sure. But fundamentally, this is the single thing that's abnormal that causes most of the problems involved with HHT. And so I'm going to be mainly talking about AVMs in the, that are causing nosebleeds. And so using this slide, I'm just sort of talking in general terms what it is we actually talk about when we come up with a new treatment or therapy for anything really. So you have effectively a root cause that then causes a problem, and that problem has symptoms attached to it. And I really like this diagram of the tree because it really illustrates very well in a metaphorical sense how each one is harder to deal with than the last. As you can imagine, treating the symptoms is not a great long-term thing, but honestly, it's easier to trim the leaves than cut down the tree. Harder still then is to actually deal with the root cause and get rid of everything completely. But as you can imagine, that's tearing out a tree by its roots. And for genetic conditions, this gets even more difficult because if you actually want to address the root cause, which for genes, it's affecting every cell in your body, we're looking more along the lines of tearing out a forest by the roots. So in terms of nosebleeds and how we actually tackle those, we're sort of looking at the problem being these AVMs and the symptom being the nosebleeds themselves. So obviously when you have already started bleeding, there are various different interventions that you would consider if you have to take the ambulance into ED. Now, the main thing is to talk about prevention of bleeds themselves. And ultimately, we've had talk from Joe, who's explained quite a lot of the treatment options for that in terms of prevention. But in terms of a pharmaceutical option, because surgery is always not for everyone and can have its own set of problems, we really want to understand is what actually should we target with the drug. what drug should we use? Do we need to design a new one? And then test it. So what we initially settled on in terms of selection is focusing on how do the blood vessels form. Because it's ultimately the formation of these fragile blood vessels within the nose that then they get set off and they start bleeding. So the drug in question that I'm talking about today is avastatin, and it works against a molecule called VEGF, which is vascular endothelial growth factor. Essentially, it's the molecule that tells cells in the body that, look, it's time to create a new blood vessel here, and is effectively the main angiogenic factor, which makes avastatin anti-angiogenic. Now, avastatin itself is actually an anti-cancer drug. As you might imagine, one of the worst things that can happen if you have a cancer is for that to get a great, robust blood supply to feed it, and that's so it can, and then it would end up growing, and large cancers are very bad. And so avastatin forms part of cancer treatment by addressing that. What we're looking at, though, is sort of more of a focused approach. Instead of flooding the system with avastatin to try and make sure the cancer is not going to grow, we instead target it directly at the nose. And so we came up with a nasal spray. Avastatin itself has been trialed a few times for HST specifically. In almost all cases, the trials are quite small. Haven't got the best evidence, and very, very mixed results is the theme there. So the main thing is that we wanted to have a system where using avastatin in low doses, because it does have a lot of side effects if you inundate the system, and targeted specifically at the nose. So we came up with a system of local delivery. We were able to formulate it here at the RMH, and our clinical trials pharmacist was able to create these sort of spray bottles with it. And so what we actually did was that we took patients with confirmed genetic diagnosis, and the patients who had very significant nosebleeds, and we used this scoring system called the epistaxis severity score that Chris mentioned to effectively come up with how bad the nosebleeds were. And we covered nose bleeding over the course of half a year. And we also put in this small trial of avastatin for 10 days with this extra process of nasal cleansing. And that nasal cleansing I want to talk about because this is what we used. Now, this was probably one of the big things that actually differentiated this study, because one of the problems that we encountered with any sort of nasal spray or anything for use in HST is that with recurrent nosebleeds, there tends to be a lot of crusting, dried blood, detritus, things that would get in the way of a drug actually getting to where it needs to be, which is the lining of the nose. So what we decided upon was that if we added this extra step of nasal washout, then it would clear away everything and that the spray would be uninhibited getting there. Now, the thing is, as Joe has mentioned before about the nosebleeds, the lining of the nose is very, very fragile. It was running air past it that could trigger bleeds. Running water was also, in some patients, rather problematic in terms of actually setting off the bleeds. And if you want to derive a treatment to prevent nosebleeds, if a part of that treatment causes nosebleeds, that's not great. And so we did have a few problems with this, but At the end of the day, it's still quite important that that sort of crusting over is gotten rid of, so to actually allow the use of a nasal spray. And so this is actually one of the big problems, is that we need to effectively have a way to allow delivery to where it needs to get without it being blocked, but not make the process of removing the blockage so traumatic that it causes the bleeds as much as it prevents. So as I mentioned, we did this questionnaire in terms of how bad the nosebleeds were. And in terms of the Avastin results, we had the most success in terms of question 2, which is the duration of the nosebleeds. That saw the most substantial decrease. In terms of the results, so as you can see there on the left-hand side of the graph, that's sort of the initial ESS. It was quite severe. And that was consistent right up until t equals 0 there, which is right before the drug was first administered. Now, the drug was given for 10 days. So at the 1 week mark there, that's after 7 days of using it with 3 days left. And the results were honestly very promising. Several patients reported nosebleeds stopping entirely. Others said that the nasal washout effectively had a negative effect in terms of causing bleeds, but that it seemed to be that the Avastin would help after that. The other thing to note is that it doesn't seem to have all that much of a long-term effect. As soon as the 2 week mark, which is when they'd already been off it for 4 days, the nosebleeds had already started to return for most patients. And it also, while it wasn't completely consistent across that time period, they did generally report that there wasn't a great long-term effect. So it seems those that were able to make use of it and those it helped said that it really, really helped for those 10 days that they were on it. But unfortunately, that effect didn't really seem to last. So I suppose the other thing to mention is that Jo, when she mentioned Avastin, she did say the $800 vial. Avastin is unfortunately quite expensive and is not extended for use in HHD, so it's quite difficult to actually get out there to patients. So really we need to push it forward in a way in which if we can show it definitively being helpful, then it will actually be recorded for use. So the other part of the research here was that in terms of actually focusing on the nose bleeding, we needed to do a study of patients' quality of life in terms of a questionnaire and gathering data, because while HHD patients' quality of life had been recorded in a sort of study in other countries, Australia, we didn't really have a set for that. And we came up with this and the main thing that caused a decrease in quality of life was pain and discomfort. So that's why we're kind of honing in our efforts on the nosebleeds especially in terms of the impact on daily life. So overall, I suppose, and to conclude this, is that Avastin as a nasal spray, we had very promising results, and my microphone has just dropped down there, but it's relatively short term, and that ultimately the most controversial part of this study was the nasal cleansing, removing of the crusting, because while it does seem to be very important that we actually get rid of that to actually allow the drug in, it can also be very problematic. So we're hoping to allow a larger scale clinical trial and to allow better access to this drug to see well and truly if we can actually get these kinds of promising results in a more large scale. And hopefully actually establish a way that's sensible and easy to actually manage nosebleeds long term. So thanks.
Thank you. Any questions for Lachlan?
Yeah.
People do you need for a large scale test?
It's probably not as many as you might think in terms of establishing that sort of statistical level. And there is an understanding that being a rare disease, while in a clinical trial you want as many people as you can possibly get really, that there's only going to be so many that you can feasibly get for this level. But in terms of our sort of pilot study there, that was 10 days and 6 patients. Likewise, other studies internationally, there has been quite a few on a similar, very small scale. So honestly, getting larger than that is an uphill battle, but would go a very long way to sort of establishing as a viable treatment option.
Can I just add in that this was just a very small proof of concept in-house, but we would go out to other centres across the country and probably collaborate internationally as well. Because to gain the statistical significance to say this is actually a good idea, you do need, as you point out, big numbers.
Just another question. I think the answer to this would be probably a no, but it's not being made available to HHD patients overseas or in the university. I guess those studies would be too small as well to get in.
I can answer that. It varies from place to place. The big issue for us, and I'm actually working through a process to see if we can actually get this prescribed without large-scale clinical trials through another mechanism. It's a very laborious and slow-moving process, but I think I've had a few people approach me and say, can't we get this done? The issue is one of evidence. The second is who's going to pay for it. Now we can work out both of those. But the most important thing is knowing, because we know that the short-term effect is good, knowing what the long-term effect of avastin in the nose is. So before we give anybody something that's going to carry on for 12 years, we need to know that a long-term approach has not been in any way risky. I've not seen any evidence, and this is where we work with our international collaborators, and we'll be hearing more. Jim Gossage from the US is the key leader of the so-called NOSE study, which is an acronym for something in America, and I'm in correspondence with him.
In terms of where you find these AVMs, it's quite literally all over the body. So we're especially worried about brain and lung, and that's why we have scans for those. And obviously the nose, as we've already talked about. But additionally, the gastrointestinal tract and the liver is other places where they can be found. And there's a big notable theme here, which is to say that every single one of these places where you can find AVMs, there are lots of blood vessels, which of course, in a problem with blood vessels, you're going to look where there's lots of blood happening. So where does that leave the kidneys? So the kidneys are, like all of those other organs listed, highly vascular. They've got heaps and heaps of blood vessels, and they all need to work correctly for the organ function. But despite this, patients with HHT, we don't really see any kidney problems. It hasn't been especially well reported. There was one study, which quite literally from 1968, was when someone actually looked at this, that said that there was telangiectasia on the surface of the kidneys in HHT patients. And this, no one's really followed this up since. Additionally, there was another study that said that there was microscopic hematuria, which is to say that there was a very, very small amount of blood in the urine, maybe. Anyway, the main point of this slide is that we don't really know about the kidney. No one's really looked, at least not in the last 50 years. So we decided to have a look-see ourselves. So we decided to use a combination of tests for renal assessment. Blood and urine tests determine kidney function, and they will show you if the kidneys are working improperly, if there's anything wrong, or if they're not at peak efficiency. Meanwhile, ultrasound and MRI give you clear images of the kidney, and we can use those to actually look physically for those AVMs and other abnormalities. There's also something worth noting is that these tests are pretty comprehensive in terms of kidney function, and the actual scans, only very, very small AVMs would bypass detection from this. And I think that generally came to the agreement that AVMs that small wouldn't pose any real significance anyway. So we had 11 participants for this test. Breakdown between ALK1 mutations and endoglin. And among those, a bit over half had internal organ AVMs already reported. So this was a cohort of patients who really did present with these malformations. And we'd expect, if we're going to find them in anyone, we're going to find them in at least some of these patients. It's also worth noting that all 11 of these patients were taking supplemental iron from their symptoms. So this was a somewhat surprising result in saying that the kidneys were completely normal in testing, the function was normal, and they came up completely and utterly clean. And I've even thrown in an MRI of a completely normal kidney there for good measure. There are a couple of interesting results in that one instance there was a kidney cancer, and then another person presented with some cysts. But these are the things that you would sort of expect based off age and regular population, unlikely to be related to HHD. So at the end of the day, we found normal kidneys in these patients. And that means that we kind of then ask why. Because these are patients who have AVMs elsewhere. The kidneys have plenty of blood vessels. What's actually happening here? So in terms of actually trying to find an answer, there's some limited information at the moment. The kidneys are special in terms of how they get their blood vessels. This is because they have very distinct and well-structured blood vessels going in and out in terms of their function. And so they utilize a few different pathways for blood vessel formation, but we still don't really understand those all that well. So this is quite interesting in terms of, if you start thinking about, well, there's this one organ that is exceptional in terms of stopping itself from getting these malformations. Exactly what's actually going on. And then if we're able to sort of dive into this a bit deeper and sort of understand the process of how it escapes these AVMs, you could, down the track, sort of improve understanding of what's actually happening here. And honestly, this is the kind of thing that you actually start to learn about new targets for drugs or new ways to manage symptoms and treat causes, and really hopefully provide an avenue down the line. But in terms of what it actually means right now, you don't need to be especially worried about kidneys. In fact, it's one of the few organs that's not going to cause any problems. But do make sure to look after your kidneys anyway. So in terms of actually getting this research out there, because, well, it's not much point really in just searching for things within the Royal Melbourne and then not sharing it with anyone. We wanted to really raise awareness of both the research and the outcomes, but also of HHT generally within the medical community and specialists both in Australia and internationally. So we're able to present this at the Royal Melbourne Research Week here, and also at the HGSA conference, which is a big gathering of genetic specialists in this space. And also happy to say that this research was published in just last month's issue, actually, of the IMJ, which is everyone in the College of Physicians gets that journal. So I'm now for something completely different, in fact. The other, I suppose, assessment that we looked to do, and this is something that I've been doing fairly recently, is looking at the impact of HST on the immune system. So this one gets a bit tricky very quickly because I'm personally not 100% confident on immunology. It is a very, very, very deep rabbit hole. But thankfully, we've been working with some wonderful people who live and breathe immunology. So they sort of raised these questions to us in terms of saying, like, well, we've got this gene change and it affects this pathway. And then we had a person start to come to us and ask these questions. And when we start to think about this, because the genes that cause HHT interact with this central pathway called TGF-beta, which is transforming growth factor. And it's a signaling pathway, which means you get an initial signal and then that gets passed down through a series of molecules and then it causes something at the end. And one of those effects at the end, we think would be these specialized immune cells called natural killer cells, which are the scariest named cells in the body. But their main function is to deal with stress cells that have gone bad in some way, and most notably, they're involved in cancer response. So we had some sort of theoretical basis to suggest that HST mutations would affect these NK cells. And so with some help from the WEHI, and lovely scientist Fernando has sent me some slides with some interesting captions, I might add, to really demonstrate what's happening. And oh, that actually worked. Wow. So this is sort of the operation of natural killer cells to sort of give an idea of what we're actually looking at. So they effectively gang up on these bad cells to deal with them. And there's a set of processes in which they actually identify which cells to destroy. What we're looking at are HHT patients from Royal Melbourne that we have seen, and we're looking at 3 different mutations. We take blood from each of them and then we run them over to the WEHI for some analysis. So we sort of isolate out these natural killer cells And then we start looking at the distribution of them by sorting them into different categories. And so then we get to actually see, well, is there any difference between normal cells and HHT cells in terms of how good they are at dealing with cancer, for instance, or how good they are at making the transitions that they need to, reaching the checkpoints that they need to, normal cell behavior. Now, this is something that's still ongoing. In fact, the last blood samples were taken Friday, but so far we've seen that this is actually a fairly exciting space, and very happy to be working with the WeHi on this. And this is honestly pretty exciting in terms of actually giving some additional information back more generally, because this sort of offers greater understanding of how these cells operate more generally as well. And just lastly, I'd like to mention there's a few organizations out there that are great that we work with. So curehht.org, I think quite a few of you would be familiar with this. It has all sorts of information available, and has postings of a lot of the different research opportunities that happen in this space. It was also sort of the source and area that we used for getting that epistaxis severity score that I showed you before lunch. And then also Rare Voices Australia, who make some very sensible points in terms of saying that individually rare diseases do not affect very many people. They are rare. But with so many, I mean, right there, more than 8,000 rare diseases affected by this, represented by this organization alone, it reaches levels of about 10% of Australia's population. And this is an organization that's also done quite a lot and is starting to gain a lot more traction as well in the medical community. Okay, so thank you. Any questions?
Do you have any understanding of AVMs in spleen? Or any knowledge of those?
Well, not to, I suppose, a thorough degree. There's I'm not sure how thoroughly that's been looked at, okay, or investigated, but I haven't personally seen studies on that.
Okay.
What was the question?
Are there AVMs? What's the issue with AVMs in the spleen? The spleen is a very rich in blood vessels. We need to get Chris Barnes back for that. He's a spleen man. There is no obvious literature. Again, there's no reason to believe that any part of the body that doesn't have a lot of blood vessels can't have an involvement. And one of the questions, and certainly when we started with the renal study, the question was, are there AVMs in the kidneys? And because the kidney's job is to be a whirlpool of blood vessels and filter, maybe it just doesn't matter. And it's possible that there are AVMs in the spleen and they don't cause any trouble. So we'll come back to you, and in our Q&A, which is going to follow on now, this will be one of our questions we'll look at. Because I think I always find when I go to a conference, the lunchtime is where I learn the most. And I've already got 3 great ideas from chatting in the lunch break. And there are very few good research collaborations that didn't start with food or beer. So you'll have to edit that, Greg. But it's a really good question, Renee, and we'll certainly follow up with that. I think Lachlan's last point about the rare voices, we're all in a situation where people don't know about HHT because maybe 1 in 5,000 people has HHT. But when you think there are 25 million Australians, 1 in 5,000 is a lot of people. And when you think of the whole world, and everyone in the world gets HHT. There's some genetic problems that only occur in certain population groups, but there is no country in the world where HHT is not present. We've had a lot of interest in working together with the Japanese Society, which makes perfect sense because we're on the same time zone. And I've had some very nice discussions with some colleagues in Osaka. I think one of the other things is that whenever we get a research question and we can't answer it, we've got the whole world on our side. And the organizations that Lachlan put up, particularly Cure HHT, even if we don't have the expertise to answer a question here, we have contacts to go to. I sit on the International Scientific Advisory, and everybody on there is a different kind of medical specialist. So if I need a question about something, and you can be sure we'll be emailing someone tonight about the spleen, and they won't be having an exciting weekend with a general election, so you know, in Toronto or whatever. But these are really important. So I think the immune studies, we don't know yet enough about what's going on, but because there are people in the room who've contributed, it's important just to give you the feedback that this is not just a curiosity for curiosity's sake. This is about really learning something. Because when Lachlan started with us, we sat down and decided that he was going to be our research student and look at HHT. And there's lots of research going on, and there's lots of knowledge. So what do you do when you want to think about these questions logically? What are the gaps? What don't we know about? And we had a talk on HHT by an overseas expert, and one of our very top kidney doctors came along. And I said, that's interesting to see you here. Do you see HHT in the kidney? And she said, no, I'm here because why don't we see it? You know, and that's how we got discussing it. The same with immune system. People with HHT don't spend a lot of time in infectious diseases situations, but actually when you start to drill down, people with HHT probably do get a few more infections than most. Probably a couple of times more off school as a kid for an infection than maybe an unaffected sibling or the kid next door or other people. So why do you get infections? Well, maybe you just live in a crowded environment and everybody, you know, you get them, but maybe it's because your immune system doesn't kick in quite as quickly as other people's. So unless we look at these as potential problems, and we're not trying to make you sick, we're trying to say, are there potential problems, because then we can put something in place. And at the other end of the spectrum, there are people with, their main problem is immune deficiency, that, you know, can't go on the bus because they'll get meningitis, and they have to be on antibiotics all the time. Now, if that was important in HHT, we'd want to be sure. We know that with AVMs in the lungs, if you're going to have your teeth drilled, you need to have antibiotics. So that's for a different reason. That's because of the shunt. But it's understanding this immune system. So these scary cells that Lachlan's talking about, we don't want you to go away thinking, eek, have you got more natural killer cells? We all have natural killer cells. I call them our biological vacuum cleaners, because all of us, all the time, you know, cells die, cells get a bit crooked or whatever, and we need a mechanism to mop up bad cells. Otherwise, they'll cause problems. It's a bit like when the kids have eaten 3 bags of chips and you've got crumbs all over the carpet. The more you don't vacuum that carpet, the more messy it gets. So in come the natural killer cells, and whoosh, and that little picture that Fernando gave us is rather cute, where you vacuum up all the problems and then you move on. But that's just part of living. What we want to know is, how do they respond? In HHT, do they respond just like everyone else? Are they different? And then we haven't talked much about genetics today, and we can do that maybe. We'll do, and we've got an idea about having a conference where we have more on the genetics, because some of you have got mutations in endoglin, some of you have got mutations in ALK1, some of you have got mutations in SMAD4, and some of you may not have mutations in any genes, partly because we haven't found them yet. One of the things that we're doing that we didn't touch on is in a few families where we haven't found a mutation, but we're really sure that they've got HHT, we're doing a new technology called whole genome sequencing. And that doesn't mean we're looking at all the genes. The technology does look at all the genes, but what it does is it looks deeper into the genes. So it looks in a way that current technology can't see. So we've sent off a couple, they're in the pipeline, and watch the space. But our friends in Salt Lake City did the same technology thinking they were going to find new genes. They didn't find any new genes for HHT, but they found changes in the known genes that current tests can't find. So now we're trying to do the same here. But we don't always want to do the same as everybody does all over the world. It's quite nice to be a bit novel. If there are no other questions about Lachlan's study, what we want to do, we've got 2 more sessions for this afternoon, and I hope you haven't all got exhaustion. One is very much about audience participation, and the other is Michael Bogwitz, and he'll be here shortly. And what he's going to do is talk about a study that we undertook with some genetic counselors and myself, with a sort of an understanding, a bit of a needs assessment. What are the gaps? What do people want to know? And a lot of information, and there may be people in the room who participated in that study as well. And obviously nothing will be linked back to anybody or identified. But he'll be here in about 5 or 10 minutes. But what we wanted to do, which would have naturally been the last session, but because we'll wait for him, is talk to you guys and see if we can shape. Do you want to use my computer or just write by hand?
I can grab.
Lachlan's going to be the note taker. But I think as we get better at doing research, and as I guess we move along in terms of that agenda of a discovery and translating it into better outcomes, as we learn more about this, we learn more that actually shaping the agenda of research needs the participation of the stakeholders. So it's all very well for Lachlan and I to sit in a room upstairs and go, I wonder what the gaps are and what shall we do, and it'll be very interesting to look at NK cells. What we really need to know is what sort of questions do you guys have that could be answered? Now, one of the questions that was put to me in the lunch break, which is a brilliant question, is there any dietary regulation? Does diet play a role? And I think the more that we move along through science, the more we understand in the holistic care of an individual or the holistic health of an individual that diet plays a big role. So is diet actually important? We know that things like garlic are blood thinners. So if you go on to warfarin, which is a blood thinning tablet, you've got to go off pizza, or at least have garlic-free pizza, because it might make your blood thinner than it should be. And so one of the questions that was raised is, does diet play a role? Is this something that resonates with people? Do you think diet may play a role? Anecdotally, do people think if you eat something it makes you worse? And the story that I was told was somebody who eats in a restaurant and then has a nosebleed, and maybe there's garlic in the dinner and that's what sets it off. Is this the kind of thing that people are thinking about?
Yeah, well, I do.
Garlic makes you worse?
No,
Oh.
not garlic specifically, but red wine.
Makes you better or worse?
Worse.
Oh.
Any alcohol.
You feel better, but your symptoms are worse.
See if you get any information.
So for those of you who don't know, Trish Linke was a beautiful lady from Canada who was heavily involved in Cure HHT and sadly passed away. But her mother had this problem. And so osteomyelitis is an infection in the bone, and Staphylococcus is a common bug, which should have treatment. But unfortunately, bacteria are much cleverer than us, and they find a way to overcome the antibiotics, which is why we're very cautious about giving antibiotics. And antibiotic stewardship and controlling antibiotic resistance is one of the great challenges even now. after antibiotics have been around for a long time. So bone infections are hard to treat because to get the medicine right inside your bone is quite challenging. Again, question on notice, but my trusty slave will do that.
She wanted to come. She wanted to come, but she's quite sick at the moment.
I know.
Yeah.
I got a text, actually, I'm sure a lot of you know Angie. I got a text from her earlier saying to say hi to everyone.
You
But
told me to film it. I said, I think they're filming it.
hi Angie. She's not well today, but she was certainly in fine form at the ball.
Wasn't she?
So Angie's a great friend and a passionate supporter of the HHT movement. Other questions? So, yeah, do you want to just pop your slide back on?
Those and now the spleen.
So technically, because if you have a genetic problem, you've got so just for those of you who I don't know and don't know if you know what a gene is a code for something to be made in your body. So you've got about 22,000 genes, and each one is an active code for something to be made, like a recipe. And if you've got a mutation, which is a technical name for like a spelling mistake in that code, it will be present in all your cells. So that recipe is, from the time that you are conceived, that recipe is there, and as you grow bigger and as your body grows into all the body parts, it's present everywhere. So therefore, it's not just your lung or your skin or something like that, as opposed to most conditions which just happen to that body part. So the genes may change, but just in that body part. So that's why it runs in families, because you can then pass it on to your children. So technically, with that kind of spelling mistake, any body part could be involved. But we know from lots of experience, in most genetic disorders, only some body parts are involved. Because this is a case, and Lachlan showed that picture a couple of times, where blood vessels, arteries and veins, so arteries basically take blood away from the heart, and veins bring it back. So the arteries take your blood away full of oxygen and food, and then your veins bring back carbon dioxide and waste products, and you get rid of this through your lungs. So that's the basic premise of the blood system. And so the vessels get smaller and smaller and smaller, and they're supposed to meet through this very fine capillary mesh, so that even the tip of your finger is going to get some oxygen and some food, otherwise it'll drop off. So the important thing is that you've got blood vessels everywhere. Now what happens here is, instead of this capillary mesh forming properly, the artery and the vein, so the red blood and the blue blood, meet when the vessel's a little bit too big. And that's why they can cause shunts, and that's why they can bleed. So technically, the more blood vessels in a body part, and Rene's question about the spleen's got hundreds of blood vessels, so maybe it doesn't matter. But the more blood vessels, the more likely it is. I mean, clearly the kidney, now we've only looked at a small study, and we're calling on our colleagues elsewhere in the world with bigger populations to see if they can repeat our work, because it's great news, actually. Kidneys are really important. So it's nice to know that there's a body part that's going to be, not involved. But these are the sort of things that we're learning. Do you have a specific question?
No, I just wanted to. I know that I've had a look at the Lachlan plot. I just wanted to see if there was anything other than that. Now Renee's saying spleen.
Yeah, well,
is in addition that they're.
Just in terms of, I guess, commentary on that is this very admittedly dense slide also sort of covers prevalence of each thing. So bleeding from the nose is the most common thing by far. It says 90% there. It's 90% plus. If you have this gene change to have HHT, then you will bleed from the nose. The rest is not as definitive. So as there of lung, that about 40% develop pulmonary AVMs. Brain, 5 to 20%. It's much, much less definitive in terms of gene change, get these symptoms. And it's sort of difficult to track because there's lots and lots of different factors that go into each of these organs, and all of the genes that to pin it down to just one gene is it's very, very difficult to do. And that's why you kind of see that even with people who all have HST, some are able to live quite comfortably and not let it and not be affected too badly, while others suffer through greatly each day.
There's a concept in genetics called penetrance, which is in a gene that goes from parent to child down the generations. Some genes are 100% penetrant and always show up. Some are not. And basically what this means is how likely it is, if you've got that gene change, that mutation, that you'll show signs of it, or the proportion of people with the gene change with signs of it. Now, of course, we haven't ever looked at the whole population, so we don't know exactly what those sort of penetrance figures are. But there are genetic disorders where we can see families all the way down with very, very high levels of penetrance of the same things, and others where the gene runs in a family, but only 40% of people get signs of this. We know that in HHT, as Lachlan said, it's 90% penetrant, or if not higher. There are very few people with an HHT mutation who don't get some nosebleeds. But even within the gene, and even within the family, that varies. So some people get much worse nosebleeds than others. So what makes this penetrance happen? And this is what we don't understand. Is it the impact of other genes that you've inherited from your mum and dad on that primary gene? So why do people get an AVM in their brain and not their lungs? Why do some people get it in both? Why do some people have very bad nosebleeds? We think endoglin probably causes nosebleeds younger than ALK1. The third gene, SMAD4, causes polyps in the bowel, which the other two genes don't seem to do. The incidence of something going on in the bowel is quite low. I think, what does the figure say there? Something like 20% have bleeding. About 80% of people, if you have an endoscopy, there'll be a couple of telangiectasia in the stomach, but they just sit there and don't do much. If they're seen, they get cauterized. But we don't actually routinely go looking for them unless you have bleeding, because they're not going to cause trouble unless they bleed, and then we're going to go and look and fix them. So there are many things that we don't understand. Even though we can say you've got a mutation in this gene and it runs in your family in this way, why do people in the same family react differently? You know, why do men and women sometimes react differently? We know that from Joe's talk that hormone therapy has an impact. Is it something to do with hormones? So there is a lot to learn yet. And so while we try and answer the questions, we have to have the humility to say, it's a little bit of an iceberg and we know the tip, but there's still much to learn, which is good when we have young people, because they can keep learning and let old people go out into the snow. Now, are there any burning questions? Because I genuinely believe that the best research that can be done is in partnership with the stakeholders, the people who actually will benefit from the research. You don't have to put your hand up. Oh, I come to you now. You don't have to put your hand up, and you know, some people don't really like asking questions in common forum, and I can relate to that a bit, although I do seem to talk a lot. But actually now we've got Michael and then Robert.
You mentioned about the different genes and how they affect, there may be some similarities that affect certain ways but not always 100%. Is there any form of link ancestry between the different genes? Or are they completely separate? And also,
the TGF-beta superfamily picture. It's a great question.
Is there any link that we can see that they all have in common?
Yes. So I think I'm going to have to give you a job. Lachlan's going to put the answer up from his previous, this one here. So while we've got 20,000 genes, they don't all do their own thing. They're all a code for something. But that something's part of a pathway. So we've got all these pathways going on in our bodies, whether it's digesting or building collagen or bones, or natural killer cells taking out the rubbish. Everything works in a pathway, and there are these superfamilies of genes. So this is the TGF-beta signaling pathway, and I call it the TGF-beta superfamily. And it consists of a number of genes. I need a big stick, but you'll see the endoglin reacts up the top, HHT1, ALK1 further down, and SMAD4 further down. And all of those three genes, so all the three genes, and GDF2 is the fourth gene, but actually we never find it. We look, but we don't find it. It's vanishingly rare. All of those genes play a role in the same pathway. So the reason that your symptoms are in common is that they all interact in some way with this whole pathway that goes towards good health, which goes into the nucleus, the brain of every cell, and keeps good health working. So yeah, absolutely spot on. Does that answer your question?
I think so. So there's no connection, like causal-wise, like causation, between one affecting the other, or the
Yes. So in terms of the actual genes themselves, they're as the genome itself is effectively a really, really long book. These are each in different chapters, these genes. They're actually not really really close together. So from a genetic point of view, it's just that they end up forming this link with terms of what they actually plan out.
So it's as though the people at that table, the people in the middle table, and you were the three genes, and you're all at different tables, but ultimately you all have the same effect. You're all going to bake the same cake or cook the same pot of soup or something like that. So they're separate genes. They don't interact as genes, and we've not knowledge of anybody who's got two different genes affected. But each of those genes, separate as they are in different chapters of the book, are sort of saying the same sort of message to your body, perhaps in different languages.
So there was no there's no common ancestor who had all of these HHT genes. No, it was one person was unlucky enough to have an ALK1 mutation one day, and since then it's been passed down. It's just the initial mutations just sort of happen randomly and they get passed down, and they happen separately and distinctly.
And all people with HHT don't come from like one Adam or Eve. These are genes that can flip over by themselves. They don't have to have been inherited. So some people have no family history because that gene change has happened in them alone.
So that is spontaneous?
Yep.
Is that simply because we don't have the data to support it, or is that actually...
No, that our normal practice would be if we find a genetic disorder and we find a mutation, then we will go to both parents and see, I mean, if one parent's got it, then it's pretty straightforward. But we'll go to both parents and see if, because dominant genes tend to track in families. Recessive genes, you've got to have a matching pair from mum and dad, which is why you don't see it in the background in the family and then it turns up in an individual. But where there's a dominant gene, and there are some conditions, so they've got nothing to do with HHT, obviously, like neurofibromatosis and tuberous sclerosis are two single gene disorders. More than 60% of people with those conditions, although it's inherited in the same way, have no family history. It's just flipped over in them. Their children have a 50-50 risk. But you look at mum and dad and no sign and no mutation. So we know that genes can flip over. We don't know what causes it. Some genes we know that being an older father has a role. Some genes on the X chromosome seem a little bit more likely, but mostly we just don't know.
So that hereditary in the name of HHTs doesn't necessarily apply?
Well, it definitely does apply, because if you've got it, you can pass it on to your kids. But the gene change could have happened in you first without having come from a parent. So once you've got a gene change, a mutation, it's hereditary, it's in all your cells, it's got a 50-50 to your kids. Yeah. So we're not going to change it just to HT.
So the spontaneous ones would be a very, very small number.
Very small number. You know, if we think only 1 in 5,000 people has it, and, you know, I think everyone in the room would have experience of families, but it can happen. It had to happen somewhere. Robert, you had your hand up ages ago.
Yeah, just trying to remember a question now.
Sorry.
That's right. Linking PABMs, from my experience, I grew up as a teenager with PABMs and I had reduced oxygen levels to 80%. If there's any studies or anything to do with acquired ADD as a result of the reduced oxygen levels.
So that is a very interesting question, and one that Lachlan is typing as we speak. A little bit like the question from Sarah about liver transplants. I'm going to have to do my homework. It's really sad when you're as old as I am and you still have to go home and do homework. But I have to do homework every day. So Robert, I will come back to you with an intelligent answer, but I can't give you one just like that. So.
Can I just ask something back to the gene flipping thing? So, because obviously my mum has HHT and I've been tested and I don't. What about my children then? Can the gene be flipped and they spontaneously got it?
So penetrance is something about what shows up in you. So the signs, the physical features of a syndrome can skip a generation. But if mum has a mutation and you didn't inherit it, it's gone. Okay. You can't pass on to your children what you haven't got.
Yes. So spontaneous?
So I just to, I suppose.
1 in a trillion.
Okay.
Yeah.
I know, but she has like a blood nose over there. I'm very proud.
Everyone has the odd blood nose.
Yeah, it's in terms of, because I know there'd be quite a few people here who have it, but then also have unaffected children. That it's passed down with a 50% chance, but that doesn't apply once you no longer have it. In terms of spontaneous gene changes, you have the same chance of having a child with HHT if you don't have it as anybody just out there in the world. It doesn't really matter if you have a family history of it. If you don't have it, then that 50-50 chance is gone and is replaced by the 1 in 10 million, which is just any gene can randomly happen to maybe do something. It's not.
With one caveat, if you have a child with someone who has HHT, then you may have a child with HHT. So if you haven't inherited your mum's mutation, but your partner actually has HHT, well, that's right. And, you know, stranger things have happened than, you know, falling in love with someone at a meeting. So that would be the one explanation.
Following on with the spontaneous mutation, is there a way to test what's caused that change in that person reflecting on their parents? Is there a way to see what has changed and how?
All we can do at this stage of the game is read the sequence of the gene and then read the sequence of the parents' genes. That's a great question. So whoever works that out will get the Nobel Prize.
Yes, but the testing is of high enough quality that we can determine between mutations. For example, that if one's got the spelling mistake at the start of the gene versus a spelling mistake at the end, we can tell the difference between that. Yeah. And so then you know that you didn't actually get that copy from a parent, you instead got it somehow else.
Somehow. So we're good enough to be able to tell you where in a gene might be more of a hot spot than a cold spot, but we can't tell you if something flipped over, why. And that's the $1 million question.